Welcome to this comprehensive presentation on central nervous system tuberculosis, specifically focusing on tuberculous meningitis. Today, we will explore the life cycle of the pathogen from initial infection to CNS dissemination, deeply analyze the pharmacological properties of the standard anti-tubercular regimens, and apply this knowledge to clinical case scenarios, including the complexities of HIV co-infection. Before we begin our exploration of central nervous system, or CNS, tuberculosis, let's take a look at the key learning objectives for this lesson. By the end of this session, you should have a clear understanding of how tuberculosis can affect the brain and surrounding structures, why it is such a serious condition, and how it is managed in clinical practice. Our first objective is to understand the pathophysiology of CNS tuberculosis. This means learning how the infection develops and spreads within the body. A particularly important concept is the rich focus. A rich focus is a small tuberculous lesion that forms within the brain or meninges after the bacteria spread through the bloodstream. For long periods, this lesion may remain silent and unnoticed. However, if it ruptures, it can release Mycobacteria into the surrounding tissues and trigger tuberculous meningitis or other forms of CNS disease. Understanding the role of the rich focus helps explain how CNS tuberculosis develops and why symptoms may appear long after the initial infection. Our second objective is to examine the mechanisms of action of the medications used to treat this disease. Tuberculosis treatment relies on a combination of first-line anti-TB drugs. Each medication attacks the bacteria in a different way. Some interfere with cell wall synthesis. Others inhibit RNA production or disrupt essential bacterial metabolism. We will also discuss dexamethasone, an important adjunctive therapy. Although dexamethasone does not kill the bacteria, it helps reduce inflammation and swelling within the central nervous system, which can significantly improve patient outcomes. Our third objective is to analyze the pharmacokinetics of tuberculosis medications. In other words, we will examine what the body does to these drugs after they are administered. This includes absorption, distribution, metabolism, and elimination. Particular attention will be given to blood-brain barrier penetration. A drug must reach adequate concentrations within the central nervous system to be effective against CNS tuberculosis. We will also explore important drug interactions that can influence treatment success and patient safety. Our final objective is to apply this knowledge to real clinical situations. Understanding the science is important, but applying it to patient care is even more valuable. We will review clinical staging systems, diagnostic criteria, and treatment protocols used in modern practice. Patient case studies will help illustrate how symptoms, laboratory findings, imaging studies, and treatment decisions come together in the management of CNS tuberculosis. By combining pathophysiology, pharmacology, pharmacokinetics, diagnostics, and case-based learning, you'll develop a comprehensive understanding of one of the most challenging and important forms of tuberculosis encountered in clinical medicine. Before we dive into the details of central nervous system tuberculosis, let's take a quick look at the roadmap for this presentation. Think of this as a guide to where we're going and what you'll learn along the way. We'll begin with pathophysiology. This section will explore how CNS tuberculosis develops, from the initial infection to its most serious complications. We'll discuss how Mycobacterium tuberculosis spreads through the body and eventually reaches the central nervous system. You'll learn about the formation of the rich focus and how its rupture can trigger tuberculous meningitis and other neurological manifestations. We'll also examine the inflammatory processes responsible for brain injury, hydrocephalus, stroke, and cranial nerve dysfunction. Next, we'll move into mechanisms of action. Here, we'll explore the major anti-tuberculosis medications used in treatment. Each drug has a unique target within the bacterial cell. Some interfere with cell wall synthesis. Others inhibit nucleic acid production or disrupt critical metabolic pathways. We'll also discuss corticosteroid therapy, particularly dexamethasone. You'll see how reducing inflammation can be just as important as eliminating the infection itself. After that, we'll focus on pharmacokinetics. This is the study of what the body does to a drug after it is administered. We'll examine absorption, distribution, metabolism, and elimination. Special attention will be given to the blood-brain barrier. This protective barrier helps shield the brain from harmful substances, but it can also limit drug penetration. Understanding which medications successfully cross this barrier is essential for effective treatment of CNS tuberculosis. We'll then move into pharmacodynamics and clinical management. This section connects drug action to real-world patient care. We'll review the clinical presentation of CNS tuberculosis and discuss diagnostic tools such as cerebrospinal fluid analysis, neuroimaging, and microbiological testing. You'll also learn about disease staging and how treatment decisions are guided by disease severity. Once the foundations are established, we'll apply this knowledge through clinical case studies. These cases will help bridge the gap between theory and practice. We'll examine a typical case of CNS tuberculosis and follow the patient's journey from diagnosis to treatment. We'll also explore a more complex scenario involving HIV co-infection, where diagnosis and management often become significantly more challenging. Finally, we'll conclude with a summary of the key concepts covered throughout the presentation. We'll revisit the most important clinical and pharmacological principles to reinforce learning. To test your understanding, we'll finish with multiple-choice questions designed to assess knowledge and strengthen retention of high-yield concepts. By the end of this journey, you'll have a comprehensive understanding of CNS tuberculosis, from disease mechanisms and pharmacology to diagnosis, treatment, and real-world clinical decision-making. To understand central nervous system tuberculosis, we first need to understand the organism responsible for the disease. The causative pathogen is Mycobacterium tuberculosis, often abbreviated as M. tuberculosis or simply MTB. This bacterium is one of the most successful human pathogens in history and remains a major global health challenge. What makes Mycobacterium tuberculosis so unique? One important feature is that it is an acid-fast bacterium. This means it retains special laboratory stains even after exposure to acidic solutions. The reason lies in its unusual cell wall structure. Unlike many other bacteria, Mycobacterium tuberculosis possesses a thick, waxy, lipid-rich outer layer. This distinctive cell wall acts like a protective shield. It helps the organism survive in hostile environments and contributes to its resistance against many defense mechanisms. A key component of this protective barrier is mycolic acid. Mycolic acids are long-chain fatty acids that give the bacterial cell wall its waxy character. These molecules make the cell wall highly impermeable and difficult to penetrate. As a result, the bacterium becomes more resistant to chemical damage, dehydration, and destruction by immune cells. Another important characteristic is that Mycobacterium tuberculosis is an obligate aerobe. In simple terms, it requires oxygen to survive and multiply. This explains why the organism commonly infects highly oxygenated tissues such as the lungs. However, once infection is established, the bacteria can spread through the bloodstream and reach other organs, including the brain and meninges. This dissemination is the foundation for central nervous system tuberculosis. The remarkable resilience of Mycobacterium tuberculosis is one of the reasons tuberculosis can be so difficult to eradicate. The organism can survive for prolonged periods under adverse conditions. Its waxy cell wall helps protect it from desiccation, which means it can resist drying out more effectively than many other bacteria. Even more importantly, it has evolved sophisticated mechanisms to evade immune destruction. After being engulfed by macrophages, the body's frontline immune cells, the bacterium can interfere with normal intracellular killing processes. Instead of being rapidly destroyed, it may persist within host cells for extended periods. This ability contributes to latent tuberculosis infection, where bacteria remain alive but inactive for months or even years. If immune defenses weaken, these dormant organisms may reactivate and cause active disease. This capacity for persistence, survival, and immune evasion is central to the pathogenesis of tuberculosis. In summary, Mycobacterium tuberculosis is an acid-fast, obligate aerobic bacterium with a waxy, lipid-rich cell wall. Its key structural component, mycolic acid, provides protection against environmental stress and immune attack. These unique features make the organism highly resilient, capable of long-term survival, and particularly effective at establishing chronic infections that can eventually involve the central nervous system. To understand central nervous system tuberculosis, we first need to follow the journey of Mycobacterium tuberculosis through the body. The infection usually begins in the lungs. Transmission occurs when a person inhales tiny aerosolized droplets released by someone with active pulmonary tuberculosis. These microscopic droplets can remain suspended in the air and travel deep into the respiratory tract. Once inhaled, the bacteria reach the alveoli, the small air sacs where oxygen exchange takes place. This is where the body's first line of defense comes into action. Specialized immune cells called alveolar macrophages quickly recognize the invading bacteria and engulf them. Under normal circumstances, macrophages destroy harmful microorganisms through a series of intracellular defense mechanisms. However, Mycobacterium tuberculosis has evolved remarkable survival strategies. Instead of being easily eliminated, the bacteria can resist destruction and persist within these immune cells. In some cases, they even use macrophages as a protective environment in which to survive and multiply. This creates the foundation for the initial tuberculosis infection. Over time, the immune system attempts to contain the infection by forming granulomas. These organized collections of immune cells act like biological walls, helping isolate the bacteria and limit their spread. In many individuals, this containment is successful and the infection enters a latent phase. The bacteria remain alive but inactive, sometimes for years. However, containment is not always perfect. Some bacteria may escape from the primary lung infection and enter the bloodstream. This process is known as hematogenous dissemination. The bloodstream essentially becomes a transportation network, allowing the organisms to travel throughout the body. At this stage, tuberculosis is no longer confined to the lungs. The bacteria can reach distant organs, including bones, kidneys, lymph nodes, and the central nervous system. This is why CNS tuberculosis is generally considered a secondary infection. The brain and surrounding structures are usually not the original site of infection. Instead, they become involved after bacteria spread from a primary focus elsewhere, most commonly the lungs. Once circulating in the blood, the organisms may lodge within the brain, meninges, or other central nervous system tissues. Small tuberculous lesions can develop and remain silent for prolonged periods. Under certain circumstances, these lesions may enlarge, rupture, or trigger a powerful inflammatory response. This can ultimately lead to tuberculous meningitis, tuberculosis, hydrocephalus, stroke, and other serious neurological complications. The central nervous system becomes the unintended target of a disease that often started as a seemingly localized lung infection. In summary, tuberculosis begins with inhalation of aerosolized droplets into the lungs. The bacteria are engulfed by alveolar macrophages but may survive and persist. Through hematogenous dissemination, the organisms can spread via the bloodstream to distant organs. CNS tuberculosis typically develops as a secondary infection when Mycobacterium tuberculosis reaches and establishes infection within the central nervous system. One of the most important concepts in the pathogenesis of central nervous system tuberculosis is the rich focus. Understanding this structure helps explain how a lung infection can eventually lead to serious disease within the brain and spinal cord. So, what exactly is a rich focus? A rich focus is a small granulomatous lesion formed by Mycobacterium tuberculosis within the central nervous system. These lesions typically contain caseous necrosis, a form of tissue destruction that gives the affected area a soft, cheese-like appearance. This characteristic feature is commonly seen in tuberculosis infections throughout the body. Think of a rich focus as a tiny hidden pocket of tuberculosis infection within the nervous system. These lesions are usually formed early in the course of disease. During the initial tuberculosis infection, bacteria may escape from the lungs and enter the bloodstream. As the organisms circulate, some become lodged within tissues of the brain or spinal cord. This process is known as hematogenous seeding. The immune system responds by surrounding the bacteria with inflammatory cells, creating a granuloma. Over time, this localized collection of infection develops into what we call a rich focus. These lesions are most commonly located in the subpial and subependymal regions. The subpial region lies just beneath the pia mater, the delicate membrane that closely covers the surface of the brain and spinal cord. The subependymal region is located beneath the lining of the brain's ventricular system. These locations place the lesions near important cerebrospinal fluid pathways and meningeal structures. What makes the rich focus particularly important is its behavior. In many patients, the lesion remains clinically silent. There may be no symptoms, no neurological deficits, and no indication that infection exists within the central nervous system. The patient may feel completely well. This dormant state can persist for months or even years. During this period, the bacteria remain contained but not necessarily eliminated. The lesion essentially acts as a hidden reservoir of infection. However, the situation can change unexpectedly. If the rich focus enlarges, weakens, or ruptures, tuberculosis organisms and inflammatory material may be released into surrounding tissues. This event can trigger a powerful immune response and lead to tuberculous meningitis or other forms of CNS tuberculosis. In many cases, the rupture of a previously silent rich focus represents the critical event that transforms a latent lesion into active neurological disease. This is why the rich focus is considered a central concept in the development of CNS tuberculosis. In summary, a rich focus is a small Ca-seating granulomatous lesion formed within the brain or spinal cord following hematogenous spread of Mycobacterium tuberculosis. These lesions are commonly found in subpial or subependymal regions and may remain dormant and clinically silent for months or years. Their eventual activation or rupture plays a key role in the development of active central nervous system tuberculosis. Now that we understand the rich focus, let's explore the critical event that often leads to active central nervous system tuberculosis. For months or even years, a rich focus may remain silent and dormant. The patient may have no symptoms and no indication that infection exists within the nervous system. However, this stability can be disrupted by a single event. The trigger is the rupture of the rich focus. When the wall of the lesion breaks down, its contents are released into nearby spaces within the central nervous system. This rupture most commonly occurs into the subarachnoid space or the ventricular system. These regions contain and circulate cerebrospinal fluid, commonly known as CSF. The cerebrospinal fluid surrounds and protects the brain and spinal cord. Once rupture occurs, the infection is no longer confined to a small, isolated lesion. Instead, live Mycobacterium tuberculosis organisms gain access to the CSF. Along with the bacteria, large amounts of tubercular antigens are also released. These antigens are molecular components of the organism that the immune system recognizes as foreign. This sudden exposure creates a major problem. The immune system reacts aggressively to the presence of both the bacteria and their antigens. What follows is not a simple inflammatory reaction. It becomes a complex and rapidly expanding immune cascade. Large numbers of immune cells are recruited to the area. Inflammatory mediators and cytokines are released in significant quantities. The body's attempt to control the infection begins to generate widespread inflammation throughout the meninges and surrounding tissues. Ironically, much of the damage in tuberculous meningitis results not only from the bacteria themselves, but also from the intensity of the host immune response. As inflammation increases, the meninges become thickened and irritated. Protein-rich inflammatory exudates accumulate around the base of the brain. Blood vessels may become inflamed and narrowed. Normal cerebrospinal fluid circulation can become obstructed. Pressure within the skull may rise. These pathological changes contribute to many of the neurological complications associated with the disease. Patients may develop headaches, fever, neck stiffness, altered mental status, cranial nerve deficits, seizures, or focal neurological symptoms. Without prompt diagnosis and treatment, the condition can rapidly progress and become life-threatening. The rupture of a rich focus therefore represents a pivotal turning point in disease progression. It marks the transition from a silent, localized infection to an active inflammatory disease involving the central nervous system. This event is considered the classic mechanism underlying the development of tuberculous meningitis, or TBM. In summary, tuberculous meningitis typically begins when a dormant rich focus ruptures into the subarachnoid space or ventricular system. This releases live mycobacteria and tubercular antigens into the cerebrospinal fluid, triggering a powerful immune response. The resulting inflammation leads to the clinical onset of tuberculous meningitis and many of its serious neurological complications. One of the most dangerous aspects of central nervous system tuberculosis is not just the infection itself. Much of the damage comes from the intense inflammatory response that follows. As inflammation spreads throughout the meninges and surrounding tissues, several serious complications can develop. Let's start with the formation of thick inflammatory exudates. These exudates are collections of protein-rich, gelatinous inflammatory material that accumulate around the base of the brain. Think of them as thick layers of inflammatory debris produced by the body's attempt to fight the infection. Unfortunately, these exudates do not simply sit harmlessly in place. As they build up, they can surround and compress nearby structures. Particularly vulnerable are the cranial nerves. These nerves emerge from the base of the brain and control important functions such as eye movement, facial sensation, hearing, swallowing, and facial expression. When inflammatory exudates entrap these nerves, patients may develop cranial nerve palsies. This can result in double vision, facial weakness, hearing impairment, or difficulty swallowing. Another major consequence of CNS inflammation is vasculitis. The term vasculitis simply means inflammation of blood vessels. In tuberculous meningitis, inflammatory cells can infiltrate the walls of cerebral arteries and other blood vessels supplying the brain. As inflammation progresses, the vessel walls become thickened and damaged. The lumen, or inner channel of the vessel, may become narrowed. In some cases, blood clots form within these vessels. This process is known as thrombosis. When blood flow is reduced or completely blocked, parts of the brain are deprived of oxygen and nutrients. The result can be an ischemic infarction, more commonly known as a stroke. These strokes may lead to weakness, paralysis, speech difficulties, cognitive impairment, or other focal neurological deficits. A third major complication is hydrocephalus. Under normal circumstances, cerebrospinal fluid circulates continuously through the ventricles and around the brain and spinal cord. The fluid is constantly produced, circulated, and reabsorbed. However, inflammatory exudates can disrupt this delicate system. They may block normal cerebrospinal fluid pathways or interfere with fluid resorption. As a result, cerebrospinal fluid begins to accumulate. This excess fluid causes enlargement of the ventricular system and increases pressure within the skull. This condition is known as hydrocephalus. As intracranial pressure rises, patients may develop severe headaches, vomiting, confusion, reduced consciousness, and other neurological symptoms. If left untreated, elevated intracranial pressure can become life-threatening. In summary, the inflammatory response in CNS tuberculosis can produce devastating complications. Thick gelatinous exudates may entrap cranial nerves and cause palsies. Vasculitis can damage cerebral blood vessels, leading to thrombosis and ischemic strokes. Obstruction of cerebrospinal fluid flow can result in hydrocephalus and elevated intracranial pressure. Together, these complications account for much of the morbidity and mortality associated with tuberculous meningitis. Now that we understand how central nervous system tuberculosis develops, let's explore how it is treated. The treatment strategy is designed to attack the infection from multiple angles at the same time. This approach is especially important because Mycobacterium tuberculosis is a resilient organism with the ability to survive in different metabolic states. Some bacteria are actively growing and dividing. Others remain dormant and metabolically inactive. A single drug cannot effectively eliminate all of these bacterial populations. That is why the intensive phase of treatment uses a combination of medications. The goal is twofold. First, rapidly reduce the number of living bacteria. Second, eliminate hidden bacterial populations that could later reactivate and cause relapse. Using multiple drugs also helps prevent the development of drug resistance. If only one medication is used, naturally resistant bacteria may survive and multiply. Combination therapy dramatically reduces this risk. The standard first-line treatment regimen consists of 4 major anti-tuberculosis agents. These are Isoniazid, Rifampicin, Pyrazinamide, and Ethambutol. Each drug targets the bacterium in a different way. Together, they create a coordinated attack against the infection. Isoniazid is highly effective against rapidly dividing organisms. Rifampicin targets bacterial RNA synthesis and has potent bactericidal activity. Pyrazinamide is particularly useful against bacteria residing in acidic environments, including those hidden within inflammatory lesions. Ethambutol serves as an important companion drug that helps prevent the emergence of resistance while contributing additional antimicrobial activity. Because each medication acts on a different target, the overall regimen becomes much more effective than any individual drug alone. However, treating CNS tuberculosis involves more than simply killing bacteria. A major component of the disease process is inflammation. As we discussed earlier, much of the neurological damage results from the host immune response rather than direct bacterial invasion alone. This is where adjunctive therapy becomes important. Dexamethasone, a corticosteroid, is commonly added to treatment. Unlike the anti-TB drugs, dexamethasone does not kill Mycobacterium tuberculosis. Instead, it helps reduce inflammation, cerebral edema, and tissue injury within the central nervous system. By controlling excessive inflammation, dexamethasone can decrease complications and improve clinical outcomes. The overall treatment strategy therefore combines antimicrobial therapy with inflammation control. The anti-TB drugs work to eliminate the infection. Dexamethasone helps protect the brain from the harmful effects of the inflammatory response. In summary, the intensive phase of CNS tuberculosis treatment relies on a multi-drug strategy using isoniazid, rifampicin, pyrazinamide, and ethambutol. This approach targets multiple bacterial populations, prevents drug resistance, and promotes rapid bacterial killing. Adjunctive dexamethasone helps control inflammation and reduce neurological damage. Together, these therapies aim to achieve both rapid bactericidal activity and long-term sterilization of dormant bacterial reservoirs. Let's begin our discussion of the first and most important anti-tuberculosis drug, isoniazid, commonly known as INH. Isoniazid has been a cornerstone of tuberculosis treatment for decades. Its effectiveness comes from its ability to target one of the most critical structures in Mycobacterium tuberculosis, the bacterial cell wall. Interestingly, isoniazid is not active when it first enters the bacterial cell. It is what we call a prodrug. A prodrug is a medication that must be converted into its active form before it can exert its therapeutic effect. In the case of isoniazid, this activation occurs inside the tuberculosis bacterium itself. The key enzyme responsible for this process is called KATG. KATG is a mycobacterial catalase peroxidase enzyme. Think of KATG as the molecular switch that turns isoniazid from an inactive compound into a powerful antibacterial weapon. Once activated, isoniazid begins targeting an essential bacterial enzyme known as INHA. INHA functions as an N-oil acyl carrier protein reductase. While the name may sound complicated, its role is straightforward. This enzyme participates in the production of mycolic acids, which are vital building blocks of the mycobacterial cell wall. Remember, mycolic acids are what give Mycobacterium tuberculosis its thick, waxy, lipid-rich outer coating. This unique structure helps protect the bacterium from environmental stress, immune attack, and many antimicrobial agents. Without mycolic acids, the organism loses one of its most important defense mechanisms. When activated, isoniazid inhibits INHA, the production of mycolic acids is dramatically reduced. As a result, the bacterium can no longer properly construct or maintain its cell wall. This is a devastating blow to the organism. The cell wall becomes weakened and unstable. Its protective barrier begins to fail. The bacterium becomes increasingly vulnerable to damage and ultimately dies. In simple terms, Isoniazid attacks the tuberculosis bacterium at its structural foundation. Instead of directly destroying the organism from the outside, it prevents the bacterium from building the protective wall it needs to survive. This mechanism explains why isoniazid is particularly effective against actively growing and dividing mycobacteria. These rapidly multiplying organisms require constant production of new cell wall material. By blocking this process, isoniazid can produce powerful bactericidal activity during the intensive phase of treatment. In summary, isoniazid is a prodrug that requires activation by the mycobacterial KATG enzyme. Once activated, it inhibits the enzyme INHA, disrupting the synthesis of mycolic acids. Because mycolic acids are essential components of the mycobacterial cell wall, their loss weakens the organism's protective barrier and ultimately leads to bacterial death. This makes isoniazid one of the most effective first-line agents in tuberculosis therapy. Now let's turn our attention to another cornerstone of tuberculosis treatment: rifampicin, often abbreviated as RIF. If isoniazid attacks the bacterial cell wall, rifampicin attacks something equally essential: the bacterium's ability to produce genetic instructions. To survive, grow, and multiply, Mycobacterium tuberculosis must constantly create proteins. Proteins are responsible for virtually every function within the bacterial cell. But before proteins can be produced, the bacterium must first generate RNA. This is where rifampicin exerts its powerful effect. Its primary target is an enzyme called DNA-dependent RNA polymerase. This enzyme acts like a molecular copying machine. Its job is to read the bacterial DNA and produce RNA transcripts that contain the instructions needed for protein synthesis. Without this process, the bacterium cannot manufacture the proteins required for survival. Rifampicin specifically binds to the beta subunit of DNA-dependent RNA polymerase. This subunit is encoded by the bacterial RPOB gene. The interaction occurs at a highly specific site on the enzyme. Once rifampicin binds, it creates a physical obstruction. This mechanism is often described as steric occlusion. In simple terms, rifampicin blocks the path that the growing RNA strand would normally follow. Imagine placing a barrier across a railway track. The train may start moving, but it cannot continue its journey. In the same way, RNA synthesis begins but cannot proceed normally. The elongation of the RNA transcript is interrupted. As a result, complete RNA molecules cannot be produced. This has profound consequences for the bacterium. Without RNA, the cell loses its ability to direct protein production. Without proteins, essential cellular functions begin to fail. Metabolism slows, repair mechanisms stop working, and bacterial survival becomes impossible. Ultimately, the organism dies. One of the most important clinical features of rifampicin is its remarkable sterilizing activity. While some anti-tuberculosis drugs are most effective against actively dividing organisms, rifampicin has the ability to eliminate bacterial populations that may be metabolically less active. This characteristic makes it a critical component of combination therapy. Its sterilizing effect helps reduce the number of persistent organisms that could otherwise survive treatment and cause relapse later. Because of this property, rifampicin is often considered the most important sterilizing agent in standard tuberculosis treatment regimens. Its inclusion significantly improves treatment success and contributes to shorter, more effective therapeutic courses. In summary, Rifampicin targets DNA-dependent RNA polymerase by binding to its beta subunit, which is encoded by the RPOB gene. This creates a physical blockade that prevents normal RNA transcript elongation. As RNA synthesis stops, protein production ceases, leading to bacterial death. Its exceptional sterilizing activity makes rifampicin one of the most powerful and indispensable drugs in tuberculosis therapy. Next, let's explore pyrazinamide, commonly known as PZA. Pyrazinamide is one of the most fascinating drugs in tuberculosis therapy because it works in places where many other medications are less effective. Like Isoniazid, pyrazinamide is a prodrug. This means the medication is initially inactive and must be converted into an active form inside the tuberculosis bacterium. The activation process depends on an enzyme called pyrazinamide. This enzyme is produced by Mycobacterium tuberculosis and is encoded by the PNCA gene. Once pyrazinamide enters the bacterial cell, pyrazinamide converts it into its active metabolite, known as pyrazinoic acid, or POA. This activated compound is responsible for the drug's antibacterial effects. Unlike some tuberculosis drugs that target a single pathway, pyrazinoic acid appears to attack the bacterium through multiple mechanisms. One important effect is disruption of cell membrane transport. The bacterial membrane serves as a gateway that regulates the movement of nutrients and other essential molecules. When this transport system is disrupted, the organism struggles to maintain normal cellular function. Pyrazinoic acid also interferes with energy production. Every living cell requires energy to survive, repair itself, and carry out metabolic activities. By disrupting bacterial energy metabolism, pyrazinamide weakens the organism and reduces its ability to persist within host tissues. Another important target is fatty acid synthase 1, commonly called FAS1. This enzyme contributes to the production of fatty acids that are essential for maintaining cellular integrity and normal bacterial function. Inhibition of this pathway further compromises the survival of the organism. What makes pyrazinamide truly unique is its activity in acidic environments. This feature distinguishes it from many other anti-tuberculosis drugs. Areas of active tuberculosis infection often contain acidic conditions. Examples include inflamed tissues, necrotic lesions, and the interiors of macrophages where bacteria may be hiding. These acidic environments can be challenging locations for antimicrobial therapy. Fortunately, pyrazinamide becomes particularly effective under these conditions. Its activity actually increases in acidic settings, allowing it to target bacterial populations that may be difficult for other drugs to eliminate. This property is especially important because some of these organisms exist in a semi-dormant state. Although they are not rapidly multiplying, they can survive treatment and later contribute to disease relapse. By targeting these hidden bacterial reservoirs, pyrazinamide plays a critical role in shortening treatment duration and improving overall treatment success. In summary, pyrazinamide is a prodrug activated by the bacterial enzyme pyrazinamide, which is encoded by the PNCA gene. The resulting active metabolite, pyrazinoic acid, disrupts membrane transport, interferes with energy metabolism, and inhibits important metabolic pathways such as fatty acid synthesis. Its greatest advantage is its potent activity in acidic environments, making it highly effective against persistent bacterial populations that are often difficult to eradicate. Now let's examine Ethambutol, often abbreviated as EMB. Ethambutol is an important member of the first-line anti-tuberculosis treatment regimen. While it may not receive as much attention as Isoniazid or Rifampicin, it plays a crucial role in successful tuberculosis therapy. Its primary function is to weaken the bacterial cell wall and help prevent the development of drug resistance. To understand how ethambutol works, we need to look at the unique structure of the mycobacterial cell wall. The cell wall of Mycobacterium tuberculosis is far more complex than that of many other bacteria. It contains several interconnected layers that provide strength, protection, and resistance to environmental stress. One of the key structural components is a molecule called arabinogalactan. This substance acts like a scaffold within the cell wall, helping connect important structural elements and maintain the integrity of the bacterial envelope. Ethambutol specifically targets enzymes known as arabinosyl transferases. These enzymes are responsible for assembling arabinos containing components of arabinogalactan. The genes that encode these enzymes are located within the EMBCAB operon. This genetic region is essential for the proper construction of the mycobacterial cell wall. When ethambutol inhibits arabinosyl transferases, the bacterium can no longer efficiently polymerize arabinos into arabinogalactan. In simple terms, it disrupts a critical construction process. Imagine trying to build a bridge without enough support beams. The structure may begin to form, but it will be weak and unstable. A similar situation occurs within the bacterial cell wall. As arabinogalactan synthesis becomes impaired, the integrity of the entire cell wall complex is compromised. The protective barrier becomes defective and less capable of supporting normal bacterial survival. Unlike some anti-tuberculosis drugs that directly kill bacteria, ethambutol is generally considered bacteriostatic. This means it primarily inhibits bacterial growth and replication rather than causing immediate bacterial death. By slowing bacterial multiplication, ethambutol gives the immune system and companion drugs a greater opportunity to eliminate the infection. Perhaps its most important clinical role is resistance prevention. During the early phase of treatment, there may be bacterial populations with varying susceptibility to different drugs. Including ethambutol in the regimen reduces the likelihood that resistant organisms will survive and become dominant. This protective effect helps preserve the effectiveness of the entire treatment strategy. For this reason, ethambutol serves as an important companion drug during the intensive phase of tuberculosis therapy. In summary, ethambutol targets arabinosyl transferase enzymes encoded by the EMBCAB operon. By preventing the incorporation of arabinos into arabinogalactan, it disrupts construction of the mycobacterial cell wall complex. Although primarily bacteriostatic, its major contribution is slowing bacterial growth and helping prevent the emergence of drug resistance during treatment. Now let's discuss dexamethasone, one of the most important adjunctive therapies used in central nervous system tuberculosis. Unlike the anti-TB drugs we have discussed so far, dexamethasone does not directly kill Mycobacterium tuberculosis. Instead, its primary role is to control the harmful inflammatory response that develops within the central nervous system. Dexamethasone belongs to a class of medications known as synthetic glucocorticoids. These drugs mimic the actions of cortisol, a natural hormone produced by the adrenal glands. Their effects are powerful, widespread, and particularly useful in conditions characterized by excessive inflammation. To understand how dexamethasone works, we need to look inside the cell. After entering a cell, Dexamethasone binds to intracellular glucocorticoid receptors. This drug-receptor complex then travels into the nucleus, where it can influence gene expression. One important mechanism is called transactivation. In this process, dexamethasone increases the transcription of anti-inflammatory genes. These genes produce proteins that help calm the immune response and limit tissue injury. Think of transactivation as turning on the body's natural anti-inflammatory systems. At the same time, dexamethasone also works through a second mechanism known as transrepression. This process is equally important. Here, the drug suppresses the activity of key pro-inflammatory transcription factors. Two of the most important targets are NF-kappa B, often written as NF-kappa B, and activator protein 1, or AP1. These transcription factors normally stimulate the production of inflammatory cytokines and other mediators of immune activation. When dexamethasone inhibits them, the inflammatory cascade begins to slow down. As a result, fewer inflammatory signals are produced. Less inflammation means less tissue damage. This mechanism is particularly important in tuberculous meningitis. Remember, much of the neurological injury in CNS tuberculosis results from the host immune response rather than the bacteria alone. Excessive inflammation can damage blood vessels, obstruct cerebrospinal fluid pathways, and increase pressure within the skull. By suppressing these inflammatory processes, dexamethasone helps protect vulnerable brain tissue. Clinically, this leads to several important benefits. Cerebral edema, or brain swelling, is reduced. Inflammation of cerebral blood vessels, known as vasculitis, becomes less severe. The release of inflammatory cytokines is also diminished, helping prevent the destructive immune amplification sometimes referred to as a cytokine storm. Together, these effects can reduce neurological complications and improve patient outcomes. In summary, dexamethasone is a synthetic glucocorticoid that modifies gene expression through both transactivation and transrepression. It enhances the production of anti-inflammatory proteins while suppressing major inflammatory pathways such as NF-kappa B and activator protein 1. The result is reduced cerebral edema, decreased vasculitis, and better control of inflammation within the central nervous system, making it a valuable adjunctive therapy in tuberculous meningitis. One of the greatest challenges in tuberculosis treatment is the development of drug resistance. Tuberculosis bacteria are constantly evolving. Small genetic changes can sometimes help the organism survive exposure to medications that would normally kill it. When these mutations occur, treatment becomes more difficult, more prolonged, and often less successful. Let's look at how resistance develops against the major first-line anti-TB drugs. We'll start with Isoniazid, or INH. Remember that Isoniazid is a prodrug. It must be activated inside the bacterium before it can work. This activation depends on the KATG enzyme. If mutations occur in the KATG gene, the enzyme may lose its ability to activate the drug effectively. As a result, Isoniazid remains inactive and cannot exert its antibacterial effect. Another mechanism involves mutations in the INHA promoter region. These mutations can increase production of the drug's target enzyme, making it harder for Isoniazid to inhibit the pathway successfully. Next is Rifampicin, one of the most important sterilizing agents in tuberculosis therapy. Rifampicin works by binding to the beta subunit of DNA-dependent RNA polymerase. This binding site is encoded by the RPOB gene. Mutations in the RPOB gene can alter the shape of the binding site. Think of it as changing the lock so the key no longer fits. Even if rifampicin is present, it can no longer attach effectively to the enzyme. Without binding, the drug loses its ability to block RNA synthesis. Now let's consider pyrazinamide, or PZA. Like isoniazid, pyrazinamide is also a prodrug. It requires activation by the enzyme pyrazinamide. This enzyme is encoded by the PNCA gene. Mutations in PNCA may prevent proper activation of the drug. Without conversion to its active form, pyrazinamide cannot generate pyrazinoic acid and therefore loses much of its antibacterial activity. Finally, we have ethambutol. Ethambutol targets arabinosyl transferase enzymes involved in cell wall synthesis. Mutations commonly occur in the EMBB gene, which is part of the EMBCAB operon. These genetic changes can alter the drug's target and reduce ethambutol's binding affinity. In simple terms, the medication can no longer attach as effectively to the enzyme it was designed to inhibit. As a result, bacterial growth continues despite treatment. The important lesson is that resistance often develops through changes in drug activation pathways or alterations in drug targets. These genetic mutations reduce drug effectiveness and allow bacteria to survive. This is precisely why combination therapy is so important in tuberculosis management. By attacking the organism through multiple mechanisms simultaneously, the likelihood of resistant strains emerging is dramatically reduced. In summary, resistance to first-line anti-TB drugs arises through specific genetic mutations. KATG and INHA mutations affect isoniazid, RPOB mutations affect rifampicin, PNCA mutations affect pyrazinamide, and EMBB mutations reduce susceptibility to ethambutol. Understanding these mechanisms is essential for appreciating both the challenges of drug-resistant tuberculosis and the importance of multi-drug therapy. Now that we've explored each medication individually, let's bring everything together with a quick summary of the key mechanisms of action. Think of this as the big picture review of how the treatment regimen attacks both the infection and the harmful inflammation it causes. Let's start with isoniazid, or INH. Isoniazid is a prodrug that must first be activated by the bacterial KATG enzyme. Once activated, it targets the INHA enzyme. This action blocks the synthesis of mycolic acids, which are essential building blocks of the mycobacterial cell wall. Without mycolic acids, the bacterium loses its protective outer barrier and becomes vulnerable to destruction. In simple terms, isoniazid weakens the bacterial fortress by preventing construction of its walls. Next is rifampicin. Rifampicin targets DNA-dependent RNA polymerase. More specifically, it binds to the beta subunit encoded by the RPOB gene. This binding blocks RNA synthesis. Without RNA, the bacterium cannot produce proteins. Without proteins, survival becomes impossible. Rifampicin essentially shuts down the organism's ability to read its genetic instructions and carry out vital cellular functions. Now let's look at pyrazinamide, or PZA. Like isoniazid, pyrazinamide is also a prodrug. It requires activation by the bacterial enzyme pyrazinamide, which is encoded by the PNCA gene. The active form, pyrazinoic acid, disrupts membrane transport, interferes with energy production, and inhibits important metabolic pathways such as fatty acid synthesis. Its greatest strength is its activity in acidic environments, where many persistent bacteria tend to hide. This makes pyrazinamide especially valuable for eliminating difficult-to-reach bacterial populations. Moving on to ethambutol. Ethambutol targets arabinosyl transferase enzymes involved in the production of arabinogalactan, a critical component of the mycobacterial cell wall. These enzymes are associated with the EMBC-AB genetic region, particularly the EMBB gene. By disrupting arabinogalactan synthesis, ethambutol weakens cell wall integrity and slows bacterial growth. Its major clinical contribution is helping prevent the emergence of drug resistance during combination therapy. Finally, let's discuss dexamethasone. Unlike the anti-TB drugs, dexamethasone does not directly attack the bacterium. Instead, it targets the host inflammatory response. Dexamethasone suppresses major inflammatory transcription factors, including NF-kappa B and AP1. These molecules normally drive the production of inflammatory cytokines. By inhibiting these pathways, dexamethasone reduces cerebral edema, vasculitis, and excessive inflammation within the central nervous system. This helps protect brain tissue from immune-mediated damage. In summary, each medication has a unique role. Isoniazid blocks mycolic acid synthesis. Rifampicin blocks RNA production. Pyrazinamide disrupts membrane function and energy metabolism. Ethambutol inhibits arabinogalactan formation. Dexamethasone controls harmful inflammation. Together, these agents create a powerful strategy for treating CNS tuberculosis while minimizing both bacterial survival and inflammatory injury. When treating central nervous system tuberculosis, choosing the right drug is only part of the challenge. The medication must also reach the site of infection. This brings us to one of the most important pharmacokinetic concepts in CNS infections: blood-brain barrier penetration. The blood-brain barrier, often called the BBB, is a highly specialized protective system. Its job is to shield the brain from toxins, pathogens, and potentially harmful substances circulating in the bloodstream. While this protection is essential for normal brain function, it also creates a major obstacle for drug therapy. A medication cannot effectively treat CNS tuberculosis if it cannot reach adequate concentrations within the cerebrospinal fluid and brain tissue. Let's look at how the major anti-tuberculosis drugs perform. First, we have isoniazid and pyrazinamide. These drugs demonstrate excellent penetration into the central nervous system. In fact, concentrations in the cerebrospinal fluid often approach those found in plasma. This means that significant amounts of the drug successfully cross the blood-brain barrier and reach the site of infection. Their strong CNS penetration is one of the reasons they are considered key components of treatment for tuberculous meningitis. Next is rifampicin. Rifampicin also enters the central nervous system, but to a lesser extent. Typically, cerebrospinal fluid concentrations reach about 10 to 20% of plasma levels. Although this penetration is lower than that of isoniazid or pyrazinamide, rifampicin remains highly valuable because of its potent bactericidal and sterilizing activity. Even at these concentrations, it plays a critical role in eliminating Mycobacterium tuberculosis from the CNS. Now let's consider ethambutol. Ethambutol has more variable penetration into the cerebrospinal fluid. Levels generally range from 10 to 50% of plasma concentrations. Its ability to enter the CNS often improves when inflammation is present. During active meningitis, the blood-brain barrier becomes more permeable. This increased permeability allows greater amounts of ethambutol to reach the site of infection. However, penetration remains less predictable than with isoniazid or pyrazinamide. Finally, let's discuss streptomycin. Unlike the other drugs we've mentioned, streptomycin has poor penetration into the central nervous system. Under normal circumstances, only minimal amounts enter the cerebrospinal fluid. Because of this limitation, its usefulness in treating CNS tuberculosis is significantly reduced compared with agents that achieve higher CNS concentrations. The key takeaway is simple. Successful treatment of CNS tuberculosis depends not only on antimicrobial potency, but also on effective drug delivery across the blood-brain barrier. Isoniazid and pyrazinamide provide excellent CNS exposure. Rifampicin offers useful penetration along with strong sterilizing activity. Ethambutol achieves moderate penetration, especially during inflammation. Streptomycin, however, enters the CNS poorly and is therefore less effective for infections located behind the blood-brain barrier. Understanding these differences helps explain why specific drugs are chosen for the treatment of tuberculous meningitis and other forms of CNS tuberculosis. Let's take a closer look at the pharmacokinetics of two key anti-tuberculosis drugs, Isoniazid and Pyrazinamide. Understanding how these medications are processed by the body helps explain both their effectiveness and their potential side effects. We'll start with Isoniazid, often called INH. After absorption, Isoniazid is distributed throughout the body and achieves excellent penetration into the central nervous system. However, before it can be eliminated, it must be metabolized. This process occurs primarily in the liver. The key metabolic pathway is called N-acetylation. The enzyme responsible for this reaction is known as N-acetyltransferase 2, or NAT2. Interestingly, not everyone processes isoniazid at the same rate. Genetic differences in the N-acetyltransferase 2 enzyme create distinct groups of patients. Some individuals are known as slow acetylators. Others are classified as fast acetylators. This variation can have important clinical consequences. In slow acetylators, isoniazid remains in the body for a longer period of time. Drug concentrations stay elevated for longer durations. While this may increase antimicrobial exposure, it also increases the risk of toxicity. These patients are more susceptible to adverse effects such as hepatotoxicity. Liver injury is one of the most important complications associated with isoniazid therapy. Slow acetylators also have a higher risk of developing peripheral neuropathy. This condition may present as numbness, tingling, burning sensations, or weakness in the hands and feet. For this reason, pyridoxine supplementation is often used to reduce the risk of neuropathy during treatment. On the other hand, fast acetylators metabolize isoniazid more rapidly. The drug is cleared from the body more quickly. As a result, blood concentrations may decline sooner than expected. In some cases, this can increase the risk of suboptimal drug exposure. Lower drug levels may reduce therapeutic effectiveness, particularly if adherence is inconsistent. Now let's turn to pyrazinamide. Like isoniazid, pyrazinamide is extensively processed by the liver. After administration, it undergoes metabolic conversion to pyrazinoic acid, commonly abbreviated as POA. This metabolite is the active form responsible for the drug's antibacterial effects. Pyrazinoic acid plays a critical role in disrupting bacterial metabolism and membrane function. It is particularly effective against tuberculosis organisms residing in acidic environments. These include inflammatory lesions and intracellular compartments where bacteria often persist. Because liver metabolism is central to pyrazinamide clearance, hepatic function remains an important consideration during therapy. Monitoring for liver-related adverse effects is therefore an essential part of patient management. In summary, isoniazid is metabolized in the liver through N-acetyltransferase 2-mediated N-acetylation. Genetic differences create slow and fast acetylators, influencing both drug levels and toxicity risk. Slow acetylators are more prone to hepatotoxicity and neuropathy, while fast acetylators may experience lower drug exposure. Pyrazinamide is also metabolized in the liver, where it is converted into its active metabolite, pyrazinoic acid, which contributes significantly to its anti-tuberculosis activity. Now let's focus on rifampicin and explore what happens to this important drug after it enters the body. Rifampicin is one of the most powerful medications in the anti-tuberculosis arsenal. Its effectiveness is due not only to its mechanism of action, but also to its favorable pharmacokinetic properties. Let's begin with absorption. Rifampicin has excellent oral bioavailability. This means that a large proportion of the drug is absorbed into the bloodstream after it is taken by mouth. Under ideal conditions, absorption is efficient and reliable. However, there is an important consideration. Fatty meals can reduce or delay rifampicin absorption. When taken with high-fat foods, less drug may reach the circulation in a timely manner. For this reason, rifampicin is often recommended on an empty stomach when possible. Once absorbed, rifampicin is widely distributed throughout the body. A key feature of the drug is its lipophilic nature. Being lipophilic means it dissolves readily in fats and biological membranes. This property helps rifampicin penetrate tissues effectively and reach sites of infection that may be difficult for other drugs to access. Another interesting characteristic is enterohepatic recirculation. After rifampicin is metabolized and secreted into the bile, some of the drug enters the intestine. Rather than being completely eliminated, a portion can be reabsorbed back into the bloodstream. This recycling process prolongs drug exposure and contributes to sustained therapeutic activity. Now let's discuss one of rifampicin's most clinically important properties, often referred to as the RIF effect. Rifampicin is a potent inducer of hepatic cytochrome P450 enzymes. In simple terms, it stimulates the liver to produce larger amounts of drug metabolizing enzymes. As these enzyme levels increase, the body begins breaking down many medications more rapidly. This can significantly reduce the effectiveness of other drugs taken at the same time. Several important cytochrome P450 isozymes are affected. These include CYP1A2, CYP2C9, CYP2C19, and CYP3A4. Together, these enzymes are responsible for metabolizing a wide range of medications. Examples include anticoagulants, antiepileptic drugs, oral contraceptives, corticosteroids, antiretroviral agents, and many cardiovascular medications. When rifampicin induces these enzymes, blood concentrations of these drugs may fall substantially. As a result, treatment failure can occur if interactions are not recognized and managed appropriately. This is why medication review is such an important part of tuberculosis treatment planning. Clinicians must carefully assess potential drug interactions before and during therapy. In summary, rifampicin has excellent oral absorption, although fatty meals may impair bioavailability. Its lipophilic nature promotes extensive tissue distribution, and enterohepatic recirculation helps prolong drug exposure. Most importantly, rifampicin is a powerful inducer of hepatic cytochrome P450 enzymes, including CYP1A2, CYP2C9, CYP2C19, and CYP3A4. This RIF effect makes drug interactions one of the most important clinical considerations during treatment. Let's continue our pharmacokinetics discussion by looking at ethambutol and dexamethasone. Although these drugs serve very different purposes, understanding how the body handles them is essential for safe and effective treatment. Let's start with ethambutol. Ethambutol is an important first-line anti-tuberculosis medication. Its primary role is to inhibit bacterial growth and help prevent the emergence of drug resistance. After absorption and distribution throughout the body, most of the drug undergoes very little metabolic change. This is a key pharmacokinetic feature. Approximately 79% of ethambutol is excreted unchanged in the urine. In other words, the kidneys are responsible for removing most of the drug from the body in its active form. Because renal excretion plays such a major role, kidney function has a direct impact on ethambutol levels. When kidney function is normal, the drug is cleared efficiently. However, in patients with renal impairment, ethambutol can accumulate in the bloodstream. As drug concentrations rise, the risk of toxicity increases. This is why renal monitoring is so important during therapy. One of the most significant adverse effects associated with excessive ethambutol exposure is optic neuropathy. Patients may develop blurred vision, decreased visual acuity, or difficulty distinguishing colors, particularly red from green. These complications can become serious if elevated drug levels persist. For this reason, strict renal dose adjustment is a critical clinical consideration. Patients with reduced kidney function often require dosage modifications or extended dosing intervals to avoid drug accumulation. Now let's turn our attention to dexamethasone. Unlike ethambutol, dexamethasone is not primarily eliminated through the kidneys. Instead, it undergoes extensive metabolism in the liver. The major enzyme involved is CYP3A4, one of the most important members of the cytochrome P450 system. This enzyme converts dexamethasone into metabolites that can then be eliminated from the body. Understanding this pathway is important because CYP3A4 activity can be influenced by other medications. Some drugs inhibit CYP3A4 and slow dexamethasone metabolism. Others increase enzyme activity and accelerate drug clearance. This can affect treatment response and may require clinical monitoring. An especially important example is rifampicin. Because rifampicin is a potent CYP3A4 inducer, it can increase the metabolism of dexamethasone and reduce its circulating levels. This interaction may decrease the anti-inflammatory effects of corticosteroid therapy if not considered during treatment planning. In summary, ethambutol is eliminated primarily through the kidneys, with nearly 79% excreted unchanged in the urine. Because renal function strongly influences drug clearance, careful dose adjustment is required in patients with kidney impairment. Dexamethasone, in contrast, is metabolized in the liver through the CYP3A4 enzyme system. Understanding these pharmacokinetic pathways helps clinicians optimize therapy while minimizing the risk of toxicity and drug interactions. One of the most important concepts in tuberculosis pharmacology is something often called the rifampicin effect. This effect explains why rifampicin is involved in so many clinically significant drug interactions. Understanding it is essential for safe and effective patient management. As we discussed earlier, rifampicin is a powerful inducer of hepatic cytochrome P450 enzymes. Among these enzymes, CYP3A4 is particularly important. When rifampicin is administered, it stimulates the liver to produce larger amounts of CYP3A4. As enzyme levels increase, Many medications are metabolized and cleared from the body much faster than normal. The result is lower drug concentrations and potentially reduced therapeutic effectiveness. A classic example involves dexamethasone. Dexamethasone is commonly used in central nervous system tuberculosis to reduce inflammation, cerebral edema, and neurological complications. However, dexamethasone is metabolized primarily by CYP3A4. When rifampicin induces this enzyme, dexamethasone is broken down more rapidly. This accelerated clearance causes blood concentrations of dexamethasone to fall. As a result, its anti-inflammatory effects may become weaker. This interaction is especially important because inflammation plays a major role in the pathogenesis of tuberculous meningitis. If corticosteroid levels become inadequate, the patient may lose some of the protective benefits of therapy. To overcome this problem, clinicians often adjust the steroid regimen. In many cases, dexamethasone doses need to be increased, sometimes even doubled, to compensate for the enhanced metabolism caused by rifampicin. This adjustment helps maintain effective anti-inflammatory activity throughout treatment. The rifampicin effect is not limited to corticosteroids. Many other medications are affected as well. One important group includes antiretroviral drugs used in patients with HIV infection. For example, dolutegravir may experience reduced plasma concentrations when administered with rifampicin. This interaction often requires dose modification and careful monitoring. Oral contraceptives are another major concern. Because rifampicin accelerates their metabolism, contraceptive effectiveness may decrease. This can increase the risk of unintended pregnancy if alternative contraceptive strategies are not used. Anticoagulants can also be affected. Enhanced drug clearance may reduce anticoagulant activity and alter the intended therapeutic response. For this reason, close monitoring and dosage adjustments are frequently necessary. These interactions highlight an important principle in clinical pharmacology. Sometimes the greatest challenge is not the disease itself, but managing how medications influence one another. Whenever rifampicin is prescribed, healthcare providers must carefully review the patient's medication list and anticipate potential interactions. In summary, rifampicin induces CYP3A4 and other hepatic enzymes, accelerating the metabolism of many drugs. This can reduce dexamethasone concentrations and often necessitates higher steroid doses. Important interactions also occur with antiretrovirals such as dolutegravir, oral contraceptives, and anticoagulants. Understanding the rifampicin effect is critical for optimizing therapy and preventing treatment failure. As we discuss tuberculosis pharmacotherapy, it's important to remember that every drug must eventually leave the body. The route of elimination plays a major role in determining drug safety, dosing schedules, and monitoring requirements. This becomes especially important in patients with impaired kidney function. Let's start with rifampicin and isoniazid. These two drugs are cleared primarily through the liver. After performing their therapeutic functions, they undergo hepatic metabolism and are eventually eliminated through biliary and other metabolic pathways. Because liver clearance is the dominant route, moderate reductions in kidney function generally have less impact on their elimination. This makes rifampicin and isoniazid relatively easier to manage in patients with renal impairment. However, liver function remains an important consideration because both drugs depend heavily on hepatic processing. Now let's turn to ethambutol. Ethambutol follows a very different pattern. Unlike rifampicin and isoniazid, it relies largely on the kidneys for elimination. Most of the drug is excreted in the urine, with a significant proportion leaving the body unchanged. Because of this dependence on renal clearance, impaired kidney function can lead to drug accumulation. As ethambutol levels rise, the risk of toxicity increases. One of the most important concerns is optic neuropathy, which may present with blurred vision, decreased visual acuity, or impaired color discrimination. This is why careful dose adjustment is essential in patients with renal disease. Pyrazinamide also requires special consideration. Although the parent drug undergoes metabolism in the liver, its metabolites are largely eliminated through the kidneys. When renal function declines, these metabolites can accumulate in the body. This may increase the likelihood of adverse effects and complicate treatment. For this reason, pyrazinamide dosing often requires modification in patients with significant renal impairment. So how do clinicians manage these challenges? The solution is usually not a large reduction in the individual dose. Instead, the dosing frequency is often adjusted. In patients with advanced renal failure, ethambutol and pyrazinamide may be administered less frequently. A common approach is reducing administration to 3 times per week rather than daily dosing. This strategy helps prevent excessive drug accumulation while maintaining therapeutic effectiveness. The goal is to achieve adequate antimicrobial activity without increasing the risk of toxicity. This balance is especially important because tuberculosis treatment typically continues for many months. Small dosing errors can become clinically significant over time. In summary, Rifampicin and Isoniazid are cleared primarily through hepatic pathways and are less affected by renal dysfunction. Ethambutol depends heavily on renal elimination, while pyrazinamide metabolites are also cleared by the kidneys. In patients with renal failure, dosing schedules for ethambutol and pyrazinamide often need to be adjusted, commonly by reducing administration frequency to 3 times weekly. Understanding these elimination pathways helps clinicians maximize efficacy while minimizing toxicity. To understand why tuberculosis treatment requires multiple drugs, we need to explore an important pharmacodynamic concept. Not all anti-tuberculosis medications work in exactly the same way. Some drugs actively kill bacteria. Others primarily stop bacteria from growing. These differences are described using the terms bactericidal and bacteriostatic. A bactericidal drug directly kills bacterial cells. A bacteriostatic drug slows or stops bacterial growth, allowing the immune system and companion medications to eliminate the infection. Both strategies are important in successful tuberculosis treatment. Let's start with Isoniazid. Isoniazid is one of the most potent bactericidal agents against actively dividing Mycobacterium tuberculosis. Remember, Isoniazid blocks the synthesis of mycolic acids, which are essential components of the bacterial cell wall. Rapidly growing bacteria constantly need to build new cell wall material. When this process is interrupted, the organisms become unstable and die. This makes Isoniazid particularly effective during the early stages of treatment, when bacterial numbers are highest. Next is Rifampicin. Rifampicin is not only bactericidal but also possesses powerful sterilizing activity. This distinction is extremely important. Many tuberculosis bacteria are actively growing, but some enter a persistent or semi-dormant state. These so-called persister organisms can survive standard antibacterial attacks and later cause disease relapse. Rifampicin helps eliminate these persistent populations by blocking RNA synthesis and disrupting essential cellular functions. Because of this sterilizing effect, Rifampicin is considered one of the most valuable drugs in the entire treatment regimen. Now let's look at pyrazinamide. Pyrazinamide is also bactericidal, but it has a unique niche. Its greatest strength is activity within acidic environments. Tuberculosis lesions often contain areas of inflammation, necrosis, and low pH. These locations can be difficult for many antibiotics to penetrate effectively. Pyrazinamide becomes especially active under these conditions. It targets bacteria hiding within acidic and necrotic lesions, helping eliminate populations that might otherwise survive treatment. This unique activity contributes significantly to shortening treatment duration. Finally, we come to Ethambutol. Unlike the other first-line drugs, Ethambutol is primarily bacteriostatic. Rather than directly killing large numbers of organisms, it slows bacterial growth by disrupting cell wall synthesis. This may seem less impressive, but its role is critical. By suppressing bacterial multiplication, Ethambutol helps prevent the emergence of drug-resistant strains during therapy. In many ways, it acts as a protective partner for the more potent bactericidal agents. In summary, each drug contributes differently to tuberculosis treatment. Isoniazid is highly bactericidal against rapidly dividing bacilli. Rifampicin is both bactericidal and sterilizing, helping eliminate persistent organisms. Pyrazinamide is bactericidal within acidic and necrotic lesions. Ethambutol is primarily bacteriostatic and plays a key role in preventing resistance. Together, these complementary actions create a highly effective multi-drug strategy against tuberculosis. One of the most important tools in managing tuberculous meningitis, or TBM, is clinical staging. Clinical staging helps healthcare providers assess disease severity, estimate prognosis, and guide treatment decisions. The earlier the stage at diagnosis, the better the chances of a favorable outcome. As tuberculous meningitis progresses, inflammation within the central nervous system becomes more severe. This can affect consciousness, damage cranial nerves, impair brain function, and increase intracranial pressure. To monitor this progression, clinicians commonly classify patients into 3 stages. Let's begin with stage 1. This is the earliest and most favorable stage of disease. Patients are typically conscious, alert, and fully oriented. They can usually communicate normally and perform routine activities without significant neurological impairment. At this point, there are no focal neurological deficits. In other words, there is no evidence of localized brain dysfunction such as weakness, cranial nerve palsies, or sensory loss. Although symptoms such as headache, fever, or malaise may be present, major neurological injury has not yet occurred. Prompt diagnosis and treatment during stage 1 are associated with the best outcomes. Next is stage 2. This stage represents disease progression and increasing inflammation within the brain and meninges. Patients often develop alterations in mental status. They may appear confused, forgetful, irritable, or unusually lethargic. Family members frequently notice that the patient is not behaving normally. Mild focal neurological deficits may also emerge. One common example is cranial nerve palsy. A patient may develop double vision, facial weakness, or abnormalities in eye movement due to inflammation affecting cranial nerves at the base of the brain. These findings signal that the disease is beginning to cause structural neurological damage. Without effective treatment, further deterioration can occur. This brings us to stage 3, the most severe stage. At this point, extensive inflammation and neurological injury are present. Patients may become stuporous, meaning they respond only to strong stimulation. Some progress to coma and become completely unresponsive. Severe focal neurological deficits are common. These may include hemiparesis, which is weakness affecting one side of the body. Seizures may also occur due to irritation and injury of brain tissue. Other serious complications, such as hydrocephalus, stroke, and elevated intracranial pressure, are often seen in advanced disease. Unfortunately, Stage 3 is associated with the highest risk of long-term neurological disability and mortality. The key message is simple. Tuberculous meningitis is a progressive disease. As patients move from Stage 1 to Stage 3, neurological involvement becomes increasingly severe. Early recognition and treatment are critical. The sooner therapy begins, the greater the opportunity to prevent irreversible brain injury. In summary, Stage 1 patients are conscious and neurologically intact. Stage 2 patients develop altered mental status and mild focal deficits such as cranial nerve palsies. Stage 3 patients are stuporous or comatose and often have severe neurological deficits, including hemiparesis and seizures. Understanding these stages is essential for assessing severity and guiding clinical management. Cerebrospinal fluid, or CSF analysis, plays a vital role in diagnosing tuberculous meningitis. It provides important clues about what is happening inside the brain and spinal cord. One of the key diagnostic markers is an elevated protein level. In most cases, the CSF protein concentration rises above 100 mg per deciliter. This increase occurs because inflammation damages the protective barriers around the brain, allowing more proteins to leak into the fluid. Another important finding is a significantly reduced glucose level. CSF glucose often falls below 45 mg per deciliter. This happens because both the tuberculosis bacteria and the body's immune cells consume glucose as they fight and multiply within the central nervous system. Doctors also look closely at the CSF cell count. A typical finding is lymphocytic pleocytosis, which means there is an increased number of lymphocytes in the fluid. Cell counts usually range from 100 to 500 cells per microliter. This pattern reflects the body's immune response against the tuberculosis infection. While these CSF findings strongly suggest tuberculous meningitis, laboratory confirmation is essential. Molecular diagnostic tests provide faster and more accurate results than traditional methods. One of the most widely used tests is PCR, or polymerase chain reaction. This technique detects the genetic material of Mycobacterium tuberculosis directly from the CSF sample. It helps identify the infection even when only small amounts of bacteria are present. Another powerful diagnostic tool is the GeneXpert MTB-RIF test. It not only detects tuberculosis DNA but also identifies resistance to Rifampicin, one of the most important anti-tuberculosis drugs. This information helps clinicians start the most effective treatment as early as possible. Together, elevated protein levels, low glucose levels, lymphocytic pleocytosis, and positive molecular tests provide strong evidence for the diagnosis of tuberculous meningitis. Early detection is critical because prompt treatment can significantly improve outcomes and reduce the risk of serious neurological complications. Cerebrospinal fluid, or CSF analysis, plays a vital role in diagnosing tuberculous meningitis. It provides important clues about what is happening inside the brain and spinal cord. One of the key diagnostic markers is an elevated protein level. In most cases, the CSF protein concentration rises above 100 mg per deciliter. This increase occurs because inflammation damages the protective barriers around the brain, allowing more proteins to leak into the fluid. Another important finding is a significantly reduced glucose level. CSF glucose often falls below 45 mg per deciliter. This happens because both the tuberculosis bacteria and the body's immune cells consume glucose as they fight and multiply within the central nervous system. Doctors also look closely at the CSF cell count. A typical finding is lymphocytic pleocytosis, which means there is an increased number of lymphocytes in the fluid. Cell counts usually range from 100 to 500 cells per microliter. This pattern reflects the body's immune response against the tuberculosis infection. While these CSF findings strongly suggest tuberculous meningitis, laboratory confirmation is essential. Molecular diagnostic tests provide faster and more accurate results than traditional methods. One of the most widely used tests is PCR, or polymerase chain reaction. This technique detects the genetic material of Mycobacterium tuberculosis directly from the CSF sample. It helps identify the infection even when only small amounts of bacteria are present. Another powerful diagnostic tool is the GeneXpert MTB-RIF test. It not only detects tuberculosis DNA but also identifies resistance to Rifampicin, one of the most important anti-tuberculosis drugs. This information helps clinicians start the most effective treatment as early as possible. Together, elevated protein levels, low glucose levels, lymphocytic pleocytosis, and positive molecular tests provide strong evidence for the diagnosis of tuberculous meningitis. Early detection is critical because prompt treatment can significantly improve outcomes and reduce the risk of serious neurological complications. In addition to anti-tuberculosis medications, patients with tuberculous meningitis often require important supportive treatments. These therapies help reduce complications and improve overall outcomes. One of the most commonly used adjuvant therapies is dexamethasone. This is a powerful corticosteroid that helps control inflammation within the central nervous system. When tuberculosis infects the membranes surrounding the brain, the body's immune response can cause significant swelling. This inflammation may increase pressure inside the skull and damage delicate brain tissue. Dexamethasone helps limit this inflammatory response. By reducing swelling, it can lower the risk of neurological complications such as stroke, nerve damage, seizures, and long-term disability. Treatment usually begins with a relatively high dose. This provides rapid control of inflammation during the most critical stage of the illness. However, dexamethasone should not be stopped suddenly. Instead, the dose is gradually reduced over a period of 6 to 8 weeks. This process is known as tapering. A gradual taper allows the body's adrenal glands to resume their normal hormone production. Abrupt withdrawal may lead to adrenal insufficiency, sometimes called an adrenal crisis, which can be a serious medical emergency. Another important supportive therapy is pyridoxine, also known as vitamin B6. This vitamin is routinely given alongside Isoniazid, one of the key drugs used to treat tuberculosis. The typical pyridoxine dose ranges from 10 to 25 mg per day. Although the dose is small, its benefits can be significant. Isoniazid can interfere with the body's vitamin B6 metabolism. Over time, this may lead to nerve irritation and damage. Patients may develop symptoms such as numbness, tingling, burning sensations, or weakness, particularly in the hands and feet. This condition is known as peripheral neuropathy. Pyridoxine supplementation helps prevent these complications. It protects nerve function and supports normal neurological health throughout treatment. Together, dexamethasone and pyridoxine play valuable roles in the management of tuberculous meningitis. While anti-tuberculosis drugs target the infection itself, these supportive therapies help protect the nervous system from additional harm. The overall goal is clear: reduce inflammation within the brain and spinal cord, protect nerve function, minimize complications, and give patients the best possible chance of a full recovery. When combined with timely diagnosis and effective anti-tuberculosis treatment, these adjuvant therapies can make a meaningful difference in both survival and long-term neurological outcomes. While tuberculosis medications are highly effective, they can sometimes cause serious side effects. That is why toxicity monitoring is an essential part of treatment. One of the most important concerns is hepatotoxicity, which means drug-induced liver injury. Several anti-tuberculosis medications, especially Isoniazid, Rifampicin, and Pyrazinamide, can place stress on the liver. In the early stages, liver damage may not cause obvious symptoms. Patients can feel completely normal while liver enzymes continue to rise. As toxicity progresses, symptoms may begin to appear. These can include nausea, vomiting, loss of appetite, abdominal discomfort, fatigue, dark urine, and yellowing of the skin or eyes. Doctors closely monitor liver enzyme levels, particularly AST and ALT. These blood tests help assess how well the liver is functioning. If AST or ALT levels rise to 5 times the upper limit of normal, treatment may need to be stopped temporarily. The same action is required if levels reach 3 times the upper limit of normal and the patient develops symptoms of liver injury. Prompt recognition is critical. Early intervention helps prevent severe liver damage and allows treatment to be adjusted safely. Another important toxicity to watch for is optic neuritis. This condition is most commonly associated with ethambutol, often abbreviated as EMB. Optic neuritis affects the optic nerve, which carries visual information from the eye to the brain. Damage to this nerve can interfere with normal vision. Patients may notice blurred vision or reduced visual sharpness. Colors may also appear faded or difficult to distinguish, especially shades of red and green. These symptoms should never be ignored. Any new visual changes during treatment require immediate medical evaluation. If optic neuritis is suspected, ethambutol must usually be discontinued permanently. Continuing the medication may increase the risk of lasting or irreversible vision loss. Because these complications can develop during therapy, regular monitoring is essential. Before treatment begins, patients typically undergo baseline liver function tests and visual acuity assessments. These initial evaluations provide a reference point for future comparisons. They help clinicians identify changes as early as possible. Monitoring does not stop after treatment starts. Monthly liver function tests are often performed to detect developing hepatotoxicity. Visual acuity testing is also repeated regularly, particularly in patients receiving ethambutol. This helps identify vision problems before significant damage occurs. The goal of toxicity management is simple: detect side effects early, protect vital organs, adjust treatment when necessary, and ensure that tuberculosis is treated as safely and effectively as possible. Careful monitoring allows patients to receive life-saving therapy while minimizing the risk of serious complications. Let's look at a clinical case that highlights how tuberculous meningitis can develop and why early recognition is so important. A 22-year-old university student arrives at the hospital with a history of persistent headaches and fever. These symptoms have been present for nearly 3 weeks. At first, the illness seemed mild. The headaches were bothersome but manageable. The fever came and went. Like many young adults, The student assumed it was a common viral infection that would eventually resolve. However, the symptoms did not improve. Instead, they gradually became worse over time. A few days before admission, family members noticed a concerning change. The student became increasingly confused and had difficulty concentrating. Simple conversations became challenging. Normal daily activities suddenly seemed difficult. On physical examination, doctors identified another important finding. The patient's right eyelid was drooping, a condition known as ptosis. Further neurological assessment suggested involvement of the third cranial nerve, also called the oculomotor nerve. This nerve controls several eye movements and helps keep the eyelid elevated. Cranial nerve palsies are important warning signs in tuberculous meningitis. They often occur when inflammation at the base of the brain affects nearby nerves. To investigate further, doctors performed a lumbar puncture and analyzed the cerebrospinal fluid, or CSF. The results were highly suspicious for tuberculous meningitis. The CSF glucose level was only 1.5 millimoles per liter. This was significantly lower than normal and suggested active infection within the central nervous system. The protein level measured 180 milligrams per deciliter. This marked elevation reflected inflammation and disruption of the blood-brain barrier. The cell count revealed 250 lymphocytes per microliter. This pattern, known as lymphocytic pleocytosis, is commonly seen in tuberculous meningitis. Taken together, the low glucose, high protein, and elevated lymphocyte count strongly pointed toward the diagnosis. To obtain definitive confirmation, molecular testing was performed using the GeneXpert assay. The test detected Mycobacterium tuberculosis DNA in the cerebrospinal fluid. This provided rapid confirmation of the infection. Just as importantly, the test showed that the organism was susceptible to rifampicin. This meant that one of the most effective first-line tuberculosis drugs could be used confidently in treatment. This case demonstrates a classic presentation of tuberculous meningitis. A gradual prodrome of fever and headache is followed by neurological deterioration and cranial nerve involvement. It also highlights the value of CSF analysis and rapid molecular diagnostics. Early recognition and prompt treatment can significantly improve outcomes and reduce the risk of permanent neurological damage. Now that the diagnosis has been confirmed, the next step is developing an effective treatment plan. Based on the patient's symptoms, neurological findings, and laboratory results, the diagnosis is Stage 2 tuberculous meningitis. Stage 2 disease is characterized by altered mental status and neurological deficits. In this case, the patient's confusion and third cranial nerve palsy place him in this category. Because tuberculous meningitis is a medical emergency, treatment should begin immediately. Delaying therapy can increase the risk of permanent neurological damage and other serious complications. The patient is started on the intensive phase of anti-tuberculosis treatment. This phase is designed to rapidly reduce the number of bacteria causing the infection. 4 medications are used together during this stage. These include Isoniazid, commonly called INH, Rifampicin or RIF, Pyrazinamide known as PZA, and Ethambutol, abbreviated as EMB. Each medication plays an important role. Using multiple drugs helps attack the bacteria through different mechanisms and reduces the risk of drug resistance. Isoniazid is particularly valuable because it penetrates well into the central nervous system. Rifampicin provides powerful bactericidal activity. Pyrazinamide is effective in acidic environments where bacteria may be hiding. Ethambutol adds additional protection against resistance. However, treating the infection is only part of the management strategy. Controlling inflammation inside the brain is equally important. To achieve this, intravenous dexamethasone is initiated. This corticosteroid helps reduce swelling and inflammation around the brain and its surrounding tissues. By lowering inflammation, dexamethasone can reduce intracranial pressure and decrease the risk of complications such as stroke, cranial nerve damage, and long-term neurological disability. The steroid is started at a higher dose and then gradually reduced over an 8-week period. This tapering schedule allows the body to adjust safely while maintaining control of inflammation. Stopping steroids suddenly could lead to adrenal insufficiency, which is why a gradual taper is essential. The treatment plan also includes pyridoxine, also known as vitamin B6. The patient receives 25 mg daily alongside isoniazid therapy. This simple supplement serves an important purpose. Isoniazid can interfere with vitamin B6 metabolism and increase the risk of peripheral neuropathy. Without adequate vitamin B6, patients may develop numbness, tingling, or weakness in the hands and feet. Pyridoxine helps prevent these complications and supports healthy nerve function. This comprehensive management plan targets both the infection and its consequences. Anti-tuberculosis drugs eliminate the bacteria. Dexamethasone controls inflammation. Pyridoxine protects the nervous system. Together, these interventions provide the best opportunity for recovery and help reduce the risk of long-term neurological impairment. Let's explore another important clinical scenario involving tuberculous meningitis and HIV co-infection. A 35-year-old woman is diagnosed with tuberculous meningitis. At the same time, she is living with HIV and is already receiving antiretroviral therapy. Her current HIV treatment includes dolutegravir, often called DTG. She is also using combined oral contraceptives, commonly known as COCs, for family planning. At first glance, the treatment plan may seem straightforward. However, managing tuberculosis and HIV together can be much more complex than treating either condition alone. One of the biggest challenges is the risk of drug-drug interactions. These interactions can affect how medications are absorbed, broken down, and eliminated by the body. For tuberculous meningitis, rifampicin is a cornerstone of treatment. It is one of the most effective drugs for killing tuberculosis bacteria and improving patient outcomes. However, rifampicin is also a powerful inducer of liver enzymes. In simple terms, it speeds up the body's ability to metabolize many medications. This creates a problem for patients receiving HIV treatment. Faster drug metabolism can lower the concentration of antiretroviral medications in the bloodstream. As a result, HIV drugs may become less effective. If medication levels fall too low, viral replication can increase and treatment success may be compromised. Dolutegravir is one of the medications affected by rifampicin. When these drugs are used together, clinicians often need to adjust the antiretroviral regimen or modify the dosing strategy to maintain adequate drug levels. The interaction does not stop there. Rifampicin can also reduce the effectiveness of combined oral contraceptives. This happens because the hormones contained in contraceptive pills are metabolized more rapidly in the presence of rifampicin. Lower hormone levels may decrease contraceptive protection and increase the risk of unintended pregnancy. For this reason, healthcare providers often discuss alternative or additional contraceptive methods during tuberculosis treatment. Managing patients with both HIV and tuberculous meningitis requires careful planning and close follow-up. Clinicians must balance effective tuberculosis treatment with continued HIV control. They must also ensure that reproductive health needs are addressed safely. Regular monitoring helps identify problems early and allows treatment adjustments when necessary. This case highlights an important lesson in clinical medicine. Treating a disease is not only about choosing the right medication. It is also about understanding how different drugs interact within the body. In patients with HIV and tuberculous meningitis, successful care depends on coordinating therapies, preventing interactions, and maintaining the effectiveness of every component of the treatment plan. Careful medication management can make a major difference in both short-term recovery and long-term health outcomes. Managing tuberculous meningitis in a patient with HIV requires careful coordination of multiple treatments. The goal is to control both infections while minimizing complications and drug interactions. In this case, rifampicin remains an essential part of tuberculosis treatment. However, rifampicin can significantly affect the levels of other medications in the body. One important medication affected by rifampicin is dolutegravir, commonly known as DTG. Dolutegravir is a key component of many HIV treatment regimens. Rifampicin increases the activity of liver enzymes that break down dolutegravir. As a result, dolutegravir levels in the bloodstream can fall below the therapeutic range. If drug levels become too low, HIV may not be adequately suppressed. This could increase the risk of treatment failure and viral replication. To overcome this interaction, the dolutegravir dose is adjusted. Instead of the standard once-daily regimen, the dose is increased to 50 mg twice daily. This adjustment helps maintain effective drug concentrations despite the enzyme-inducing effects of rifampicin. It allows both HIV and tuberculosis therapies to be used together safely. Contraceptive management also requires special attention. The patient is currently using combined oral contraceptives. Unfortunately, rifampicin can reduce the effectiveness of hormonal contraceptives. It accelerates the breakdown of contraceptive hormones, lowering their levels in the bloodstream. This can increase the risk of unintended pregnancy during treatment. For this reason, a more reliable option is recommended. The patient is advised to switch to a copper IUD. This method does not rely on hormones and is therefore unaffected by rifampicin. A copper IUD provides highly effective, long-term contraception while avoiding concerns about drug interactions. It remains a dependable choice throughout the tuberculosis treatment period. Another important management decision involves the timing of antiretroviral therapy, or ART. When HIV treatment is started too soon after beginning tuberculosis therapy, the recovering immune system can trigger an exaggerated inflammatory response. This complication is known as immune reconstitution inflammatory syndrome, or IRIS. In patients with tuberculous meningitis, immune reconstitution inflammatory syndrome can be particularly dangerous. Increased inflammation within the brain may worsen neurological symptoms and lead to serious complications. To reduce this risk, antiretroviral therapy initiation is often delayed. A waiting period of approximately 2 to 8 weeks after starting tuberculosis treatment may be recommended, depending on the patient's clinical condition and immune status. This approach allows initial control of the tuberculosis infection before the immune system becomes more active. The management of HIV-associated tuberculous meningitis requires more than simply prescribing medications. It involves balancing treatment effectiveness, preventing drug interactions, ensuring reliable contraception, and reducing the risk of immune reconstitution inflammatory syndrome. With careful planning and close monitoring, patients can successfully receive treatment for both conditions while achieving better long-term outcomes. Let's bring everything together with a summary of the pathophysiology and diagnosis of tuberculous meningitis. Tuberculous meningitis begins when Mycobacterium tuberculosis spreads from a primary infection site, usually the lungs, into the bloodstream. This process is known as hematogenous spread. Through the circulation, the bacteria travel to different parts of the body, including the brain and its surrounding membranes. Once inside the central nervous system, small collections of tuberculosis bacteria form beneath the meninges or within the brain tissue. These microscopic lesions are called rich foci. At this stage, patients may have no neurological symptoms. The infection can remain silent for weeks, months, or even longer. The critical event occurs when one of these rich foci ruptures into the subarachnoid space. This space contains cerebrospinal fluid, which circulates around the brain and spinal cord. When rupture occurs, tuberculosis antigens are suddenly released into the cerebrospinal fluid. The immune system responds with an intense inflammatory reaction. This inflammation is responsible for most of the damage seen in tuberculous meningitis. The bacteria initiate the process, but the body's inflammatory response often drives the complications. One major complication is the formation of basal exudates. These are thick inflammatory deposits that accumulate at the base of the brain. Basal exudates can surround and compress important cranial nerves. This may lead to neurological deficits such as double vision, facial weakness, hearing loss, or drooping of the eyelid. Another serious complication is vasculitis. Inflammation affects the walls of blood vessels supplying the brain. As these vessels become narrowed or blocked, blood flow decreases. This can result in cerebral infarctions, commonly known as strokes. Hydrocephalus is another potentially life-threatening consequence. Inflammation can obstruct the normal flow and absorption of cerebrospinal fluid. As fluid accumulates, pressure inside the skull rises. Without treatment, hydrocephalus can cause worsening neurological function and severe brain injury. Diagnosing tuberculous meningitis requires a combination of clinical suspicion and laboratory evidence. Cerebrospinal fluid analysis provides some of the most important diagnostic clues. The classic CSF profile includes a high protein concentration, reflecting inflammation and disruption of normal barriers within the brain. Glucose levels are typically low because both immune cells and tuberculosis bacteria consume glucose within the central nervous system. The cell count usually shows a predominance of lymphocytes, indicating a chronic inflammatory response. While these findings strongly support the diagnosis, molecular testing provides definitive confirmation. Polymerase chain reaction, or PCR-based tests such as GeneXpert, detect tuberculosis DNA directly in the cerebrospinal fluid. Together, the characteristic CSF profile and positive molecular testing allow clinicians to diagnose tuberculous meningitis rapidly and accurately, enabling earlier treatment and better patient outcomes. Let's conclude with a summary of the treatment and pharmacology of tuberculous meningitis. Successful treatment requires a combination of effective anti-tuberculosis medications, supportive therapies, and careful monitoring throughout the treatment course. The standard treatment begins with an intensive phase lasting 2 months. During this period, 4 medications are used together. These drugs are Isoniazid, Rifampicin, Pyrazinamide, and Ethambutol. Together, they are often remembered by the acronym HRZE. The purpose of the intensive phase is to rapidly reduce the bacterial population and prevent the emergence of drug resistance. After the initial 2 months, treatment enters the continuation phase. This stage usually lasts between 7 and 10 months. During the continuation phase, only Isoniazid and Rifampicin are continued. These medications help eliminate any remaining bacteria and reduce the risk of relapse. As a result, the total treatment duration for tuberculous meningitis is typically between 9 and 12 months. Each drug works in a different way to attack Mycobacterium tuberculosis. Isoniazid targets the bacterial cell wall. It inhibits the synthesis of mycolic acids, which are essential components of the tuberculosis cell wall. Without a functional cell wall, the bacteria become vulnerable and eventually die. Ethambutol also interferes with cell wall formation. It disrupts the assembly of important structural components, weakening the bacterial defense system. Rifampicin works through a completely different mechanism. It inhibits bacterial RNA polymerase, an enzyme required for gene transcription. Without RNA production, the bacteria cannot synthesize proteins or reproduce effectively. Pyrazinamide targets bacterial energy metabolism. It is particularly active in acidic environments where dormant bacteria may be hiding. This makes pyrazinamide especially valuable during the early stages of treatment. While these medications are highly effective, drug interactions must always be considered. Rifampicin is one of the most important examples. It is a powerful inducer of the CYP3A4 enzyme system in the liver. This means it accelerates the metabolism of many medications, including certain antiretroviral drugs, oral contraceptives, anticoagulants, and other commonly prescribed therapies. As a result, drug levels may fall and treatment effectiveness can be reduced. Careful medication review is therefore essential before and during therapy. Adjunctive treatments also play an important role in patient care. Dexamethasone is frequently used to reduce inflammation within the brain and spinal cord. By controlling swelling, it helps decrease the risk of neurological complications and improves clinical outcomes. Pyridoxine, also known as vitamin B6, is routinely administered alongside isoniazid. Its primary purpose is to prevent peripheral neuropathy, a complication that can cause numbness, tingling, and nerve dysfunction. Together, effective pharmacotherapy, awareness of drug interactions, and appropriate supportive treatments form the foundation of successful tuberculous meningitis management. Early treatment and consistent adherence remain the keys to achieving the best possible outcomes. Let's test your understanding with a quick knowledge assessment. Here's the question. The clinical onset of tuberculous meningitis is triggered by the rupture of which structure? Is it A, a Ghon complex, B, a rich focus, C, an aspergilloma, or D, a tuberculoma? Take a moment to think about your answer. The correct answer is B, a rich focus. To understand why, let's briefly review the pathogenesis of tuberculous meningitis. After the tuberculosis bacteria spread through the bloodstream, they can seed the brain and its surrounding membranes. These bacteria form tiny dormant lesions known as rich foci. These microscopic collections of infection may develop beneath the meninges or within the brain tissue itself. For a period of time, these lesions may remain silent. The patient may have no neurological symptoms at all. The critical event occurs when a rich focus ruptures into the subarachnoid space, the area that contains cerebrospinal fluid. Once rupture occurs, tuberculosis bacteria and their antigens are released into the cerebrospinal fluid. This triggers a powerful inflammatory response from the immune system. The resulting inflammation causes meningeal irritation, swelling, vascular injury, and disruption of normal cerebrospinal fluid flow. These inflammatory changes mark the beginning of the clinical disease we recognize as tuberculous meningitis. Now let's look at why the other options are incorrect. A GON complex is associated with primary pulmonary tuberculosis. It consists of a lung lesion and involved regional lymph nodes. While important in tuberculosis infection, it does not trigger the onset of tuberculous meningitis. An aspergilloma is a fungal mass caused by Aspergillus species. It is unrelated to the pathogenesis of tuberculous meningitis. A tuberculoma is a localized granulomatous mass formed by tuberculosis infection within the brain. Although it can cause neurological symptoms, it is not the structure whose rupture typically initiates tuberculous meningitis. The key concept to remember is simple. Hematogenous spread leads to the formation of rich foci. Rupture of a rich focus releases bacteria into the cerebrospinal fluid. This event triggers intense inflammation, and that inflammation produces the clinical features of tuberculous meningitis. So whenever you are asked what initiates the clinical onset of TBM, remember the sequence. Rich focus formation, rich focus rupture, inflammation, tuberculous meningitis. That's why the correct answer is B, rich focus. Let's test another important pharmacology concept with a quick knowledge check. Here's the question. Which anti-tuberculosis agent is a prodrug that must be activated by the bacterial enzyme KATG before it can inhibit mycolic acid synthesis? Is it A, Rifampicin, B, Ethambutol, C, Isoniazid, or D, Pyrazinamide? Take a moment to think about your answer. The correct answer is C, Isoniazid. Isoniazid is one of the most important first-line drugs used in the treatment of tuberculosis, including tuberculous meningitis. What makes isoniazid unique is that it is a prodrug. This means the medication is initially inactive when it enters the bacterial cell. To become effective, it must first be activated by a bacterial enzyme known as KATG. KATG is a catalase peroxidase enzyme produced by Mycobacterium tuberculosis. Once activated, isoniazid forms reactive compounds that interfere with the production of mycolic acids. Mycolic acids are essential building blocks of the mycobacterial cell wall. These fatty acids create a thick, waxy protective barrier around the bacterium. This barrier helps tuberculosis bacteria survive in harsh environments and resist destruction by the immune system. When mycolic acid synthesis is blocked, the bacterial cell wall becomes defective and unstable. Without a functional cell wall, the bacteria lose their structural integrity and eventually die. This mechanism explains why isoniazid is highly effective against actively dividing tuberculosis organisms. Now let's look at the other options. Rifampicin does not inhibit mycolic acid synthesis. Instead, it blocks bacterial RNA polymerase. By preventing RNA production, rifampicin stops protein synthesis and bacterial replication. Ethambutol affects cell wall formation, but through a different pathway. It inhibits the synthesis of arabinogalactan, another important component of the mycobacterial cell wall. Although it targets the cell wall, it is not activated by KATG and does not directly inhibit mycolic acid production. Pyrazinamide also works differently. It is converted into its active form by a bacterial enzyme called pyrazinamidase. Its primary action involves disrupting bacterial energy metabolism and membrane function, especially in acidic environments. The key point to remember is simple. KATG activates isoniazid. Activated isoniazid blocks mycolic acid synthesis. Loss of mycolic acids weakens the bacterial cell wall, and a damaged cell wall leads to bacterial death. Whenever you see the terms prodrug, KATG, and mycolic acid inhibition in the same question, think of one drug immediately. Isoniazid. That's why the correct answer is C, isoniazid. Let's test another high-yield pharmacology concept with a quick knowledge assessment. Here's the question. Rifampicin causes drug-drug interactions primarily through which mechanism? Is it A, inhibition of CYP3A4, B, potent induction of cytochrome P450 enzymes, C, competition for renal secretion, or D, protein displacement? Take a moment to choose your answer. The correct answer is B, potent induction of cytochrome P450 enzymes. Rifampicin is one of the most effective anti-tuberculosis medications. It plays a critical role in the treatment of both pulmonary tuberculosis and tuberculous meningitis. However, rifampicin is also famous for causing numerous drug-drug interactions. The reason lies in its powerful effect on liver enzymes. Rifampicin strongly induces, or increases, the activity of several cytochrome P450 enzyme systems. Among these, CYP3A4 is one of the most important. Think of these enzymes as the body's chemical processing factories. Their job is to break down and eliminate medications from the bloodstream. When rifampicin stimulates these enzymes, the factories begin working much faster than normal. As a result, many medications are metabolized more rapidly and cleared from the body sooner. This often causes drug concentrations to fall below therapeutic levels. When drug levels decrease, treatment effectiveness may also decline. This interaction can have significant clinical consequences. For example, rifampicin can reduce the levels of certain antiretroviral drugs used to treat HIV. It can also decrease the effectiveness of oral contraceptives, increasing the risk of unintended pregnancy. Other affected medications may include anticoagulants, antifungal agents, immunosuppressants, and several cardiovascular drugs. This is why a careful medication review is essential whenever rifampicin is prescribed. Now let's examine why the other options are incorrect. Option A is inhibition of CYP3A4. This is the opposite of what rifampicin does. Rifampicin induces enzyme activity rather than blocking it. Option C is competition for renal secretion. Although some drugs interact through the kidneys, this is not the primary mechanism responsible for rifampacin's extensive interactions. Option D is protein displacement. Certain medications can interact by displacing one another from plasma protein binding sites. However, this is not the major mechanism associated with rifampicin. The key concept to remember is simple. Rifampicin turns up the activity of cytochrome P450 enzymes. More enzyme activity means faster drug metabolism. Faster metabolism means lower drug concentrations. And lower concentrations can lead to reduced therapeutic effects. Whenever you encounter a question about rifampicin and drug interactions, think of one phrase immediately. Potent cytochrome P450 induction. That's the hallmark mechanism. And that's why the correct answer is B, potent induction of cytochrome P450 enzymes. Let's move on to another important knowledge assessment question. Here's the question. Co-administration of vitamin B6 is required to prevent neuropathy caused by which medication? Is it A, Isoniazid, B, Rifampicin, C, Ethambutol, or D, Dexamethasone? Take a moment to consider your answer. The correct answer is A, Isoniazid. Isoniazid is one of the most effective first-line drugs used in the treatment of tuberculosis, including tuberculous meningitis. While it is highly effective against Mycobacterium tuberculosis, it can also produce important side effects that require prevention and monitoring. One of the most common neurological side effects of isoniazid is peripheral neuropathy. Peripheral neuropathy occurs when nerves outside the brain and spinal cord become damaged or irritated. Patients may experience numbness, tingling, burning sensations, pins and needles feelings, or weakness in the hands and feet. These symptoms can gradually worsen if the underlying cause is not addressed. The reason this happens is related to vitamin B6, also known as pyridoxine. Isoniazid interferes with the body's metabolism and utilization of vitamin B6. Over time, vitamin B6 levels may become depleted. Because vitamin B6 plays an essential role in nerve function and neurotransmitter production, deficiency can lead to nerve damage. This is why pyridoxine supplementation is routinely prescribed alongside isoniazid therapy. By replacing vitamin B6, clinicians can significantly reduce the risk of developing peripheral neuropathy. The strategy is simple but highly effective. Prevent the deficiency before symptoms occur. Protect nerve function throughout treatment. And improve overall medication tolerability. Certain patients are at even greater risk for isoniazid-induced neuropathy. These include individuals with HIV infection, diabetes mellitus, malnutrition, chronic alcohol use, kidney disease, pregnancy, and older age. In these groups, vitamin B6 supplementation becomes especially important. Now let's briefly review why the other options are incorrect. Rifampicin is associated with drug interactions and potential liver toxicity, but it is not the primary cause of vitamin B6-related neuropathy. Ethambutol is best known for its risk of optic neuritis, which can affect visual acuity and color perception. Dexamethasone is a corticosteroid used to reduce inflammation and cerebral edema. It does not typically require vitamin B6 supplementation. The key point to remember is straightforward. Isoniazid can deplete vitamin B6. Vitamin B6 deficiency can lead to peripheral neuropathy. Pyridoxine supplementation helps prevent this complication. So whenever you see a question linking vitamin B6, neuropathy prevention, and tuberculosis treatment, think of one medication first. Isoniazid. That's why the correct answer is A. Isoniazid. Let's finish with another important clinical knowledge question. Here's the question. In patients with HIV co-infection, why is antiretroviral therapy, or ART, typically delayed for 2 to 8 weeks after starting treatment for tuberculous meningitis? Is it A, to prevent combined hepatotoxicity? B, to allow better renal clearance? C, to prevent immune reconstitution inflammatory syndrome, also known as IRIS? Or D, to increase drug penetration? Take a moment to think about your answer. The correct answer is C, to prevent immune reconstitution inflammatory syndrome, or IRIS. To understand this concept, let's first look at what happens in HIV infection. HIV weakens the immune system by reducing the number and function of important immune cells. As a result, the body becomes less effective at fighting infections such as tuberculosis. When antiretroviral therapy is started, the immune system begins to recover. This is generally a positive development and an important goal of treatment. However, in some cases, the recovering immune system reacts very aggressively to infections that are already present in the body. This exaggerated inflammatory response is called immune reconstitution inflammatory syndrome. In patients with tuberculous meningitis, immune reconstitution inflammatory syndrome can be particularly dangerous. As the immune system becomes more active, it may trigger intense inflammation around the brain and spinal cord. This can worsen existing neurological symptoms or cause new complications to develop. Patients may experience worsening headaches, increased intracranial pressure, new neurological deficits, seizures, or declining levels of consciousness. In severe cases, immune reconstitution inflammatory syndrome can become life-threatening. For this reason, clinicians often prioritize tuberculosis treatment first. Anti-tuberculosis medications are started immediately to reduce the burden of infection and begin controlling the disease process. Antiretroviral therapy is then introduced after a carefully selected delay, usually between 2 and 8 weeks. This timing helps strike a balance between treating HIV and reducing the risk of excessive inflammation within the central nervous system. The exact timing may vary depending on the patient's immune status, disease severity, and overall clinical condition. Now let's briefly review the other options. Option A, prevention of combined hepatotoxicity, may be a consideration when managing medications, but it is not the primary reason for delaying antiretroviral therapy in tuberculous meningitis. Option B, improving renal clearance, is not the main clinical concern in this situation. Option D, increasing drug penetration, is also not the reason antiretroviral therapy initiation is postponed. The key concept to remember is simple. Starting antiretroviral therapy restores immune function. A recovering immune system can sometimes overreact to existing infections. That overreaction is called immune reconstitution inflammatory syndrome. And in tuberculous meningitis, IRIS can significantly worsen inflammation within the brain. That's why antiretroviral therapy is often delayed for 2 to 8 weeks. The goal is to reduce the risk of IRIS while still ensuring effective treatment of both HIV and tuberculosis. So the correct answer is C, to prevent immune reconstitution inflammatory syndrome. This concludes our presentation. The material presented today synthesizes pharmacological mechanisms with current clinical guidelines on the management of tuberculous meningitis. Thank you for your attention. I am now open to any questions.